To open the next session, please welcome Dr. Heinrik Jude Strebel, Clinical Associate Professor at the University of the Philippines College of Medicine and Training Officer of the Division of Medical Oncology of the Philippine General Hospital.
Good evening, ladies and gentlemen. I'm Heinrik Martin Jude Strebel from the Philippine General Hospital. The next lecture is entitled Next Generation Sequencing and its Role in Precision Medicine. Our distinguished speaker is Professor CHeol, AOS Council Member, Director of Yonsei Songdang Institute for Cancer Research, and Director of the National Biochip Research Center, Ministry of Health and Welfare. He is the Chairman and Executive Board Member of the Korean Cancer Association, founding member of the Cancer Metastasis Research Center, Korean Science and Engineering Foundation, and Professor of Medical Oncology at Yonsei University College of Medicine. Ladies and gentlemen, please help me welcome Professor CHeol.
Good afternoon. Welcome to the Meet the Expert Session 14 under the title of Next Generation Sequencing and its Role in Precision Medicine. It is a great honor for me to have a talk in the first AOS convention, and I deeply appreciate Academic Committee for inviting me to this fantastic online academic activity in spite of COVID-19 pandemic. My name is Hyun, a medical oncologist from Yonsei Cancer Center, Yonsei University College of Medicine, Seoul, Korea. During the coming 30 minutes, I am going to talk about what is the background and stimulative factors for the precision oncology and what we are doing right now for the personalized oncology and which is the best way to go for our patient in Asia Pacific region for the next generation precision oncology. Since CHeol in GIST, many treatment selections based on biomarkers has brought remarkable advances in oncology. Identification of these pathways, technologies enabling molecular tumor profiling, and rapid discovery of targeted agents have stimulated the development of precision medicine. Therefore, screening these multiple aberrations and matching them to a drug at a time must be more efficient and informative strategy than sequencing screening of individual aberrations by classical method such as IHC, CGH, and PCR. Traditional treatment is a drug-centered strategy that finds out commonalities among patients to be grouped together and treated similarly. On the contrary, precision oncology is a patient-centered N-of-1 approach that utilizes individual treatment. Molecular aberrations do not segregate by organ of origin, and vice versa. Tumors from different organs may have similar aberrations. Genetic aberrations may have a significant impact on the management of cancer. Based on specific scientific findings, tumors having a common aberrations differ in the rest of their molecular fingerprint, the molecular backdrop. Hence, individualized therapy is required for improved oncologic outcomes. The first prospective pilot study of matching target and treatment using molecular profile was done by Dr. Prof group in 2010. They allocated patients to each treatment using IHC of 13 genes and expression array of 51 genes. The identified targets were ranked according to the protocol-specified algorithm as follows. When both IHC and the microarray indicated the same target, the target was the first priority. The second priority was genes with IHC positive result alone, and the last priority was microarray positive result alone. If two targets were identified, a combined treatment was recommended. If there is no target identified, investigator choose the chemotherapy. The primary endpoint was PFS ratio that compares the PFS by molecular profiling with the PFS for the most recent treatment. If the PFS ratio was equal or greater than 1.3, then profiling-based treatment was identified as having benefit. Of the 106 patients who consented and evaluated, 20 patients did not do profiling mainly due to progression of the cancer. And another 18 patients did not get the targeted treatment after profiling mainly due to cancer progression. Among remaining 68 patients, 66 patients got the recommended targeted treatment, while 64 patients got targeted treatment as planned. Remaining 28 patients got chemotherapy due to inability to perform biopsy or no targetable aberrations. The median tumor shrinkage was 47%, and 27% of the patients showed the PFS ratio of equal or greater than 1.3. From this first pilot trial, there were several points to learn for the next trials. First, as the PFS ratio is influenced by frequency of evaluation during PFS1 and PFS2 period, same evaluation interval during PFS1 and PFS2 is mandatory to avoid ascertainment bias. Second, as this is a non-randomized single-arm trial, the result is not conclusive. Third, among 40 lost patients, 30 were due to cancer progression. To decrease this number, shortening of profiling turnaround time and inclusion of earlier disease stage would be of interest. Finally, among 18 patients who showed higher PFS ratio, 14 patients got combined treatment, and among them, 12 patients got chemotherapy-based combination. This means a combination strategy can be a possible option for future trials. This study showed that the refractory cancers have targets and many that may provide benefit with precision oncology. Since Dr. Banov's report, there were 6 retrospective analyses from 4 institutions evaluating the value of molecular profiling in allocating patients to phase 1 trial. As you see in green box, there is a trend of technology change in molecular profiling from PCR to NGS. Targetable evolutions were achieved in 80% of the patients, and 1/4 of them got targeted treatment, as you see in red box. Even though this is a retrospective analysis, we can see higher PFS ratio than Dr. Banov's group. Even if actionable target is a moving target, identification of specific molecular abnormalities and choosing therapy to these abnormalities was relevant in phase 1 clinical trials. Therefore, personalized approach can lead to improved clinical outcome. In 2015, 2 meta-analyses were reported comparing trials with and without targeted treatment. The first study included 570 trials with 32,000 patients, and the second study included 112 trials with 38,000 patients treated with FDA-approved drugs. As you see in green box, in both studies, personalized strategy was independently associated with high ORR, longer PFS and OS, and fewer toxic deaths. Interestingly, the worst outcome was associated with the use of targeted agent in a non-personalized strategy. Personalized treatment was associated with increased benefit across tumor types in both FDA-approved and not yet approved drugs. Since 2016, four prospective studies that check the feasibility of genome-based precision medicine were reported. As you see in green box, most of the used NGS was as a backbone profiling technology with supplementary IHC, PC, or cytoscan based on the selected regions. As you can see in red box, there was a still discrepancy between high detection rate of alteration and low matching ratio, which will limit the clinical benefit. And now, I'm going to discuss about what we are doing now. Based on meta-analysis and prospective study, master protocols classified as platform, basket, umbrella trials were developed that investigate multiple hypotheses through concurrent sub-studies. Master protocol provides comprehensive and adaptive sub-studies with standardized operational structure, patient recruitment and selection method, data collection, analysis, and management system. Platform trials are referred to as multi-arm, multi-stage trials evaluating several interventions against a common control group. Pre-specified adaptation rules allow dropping of ineffective intervention or adding new intervention during the trial. Basket trial investigate the effect of agent against specific molecular aberrations across multiple histology, while umbrella trials investigate the effect of multiple targeted therapies in a single disease. Both designs may or may not use randomization. For control group, usually standard treatment or placebo are used. But in basket trial, there are many different standard treatments based on different histology. So it may not be feasible to make a common control group in basket design, and this is the main reason that most of basket trials are single-arm, non-randomized trials. But in umbrella trial design, in a single histology, it is easier to pick up control group with either standard treatment or placebo. Custom, Shiba, paper, and match trials are typical basket trials. As an umbrella design, My Pathway, I-SPY, Sapphire are breast cancer trials, LungMap, Battle, Winter are lung cancer trials, and Focus 4 is a colon cancer trial. Basket and umbrella trials can be categorized by two factors: major profiling technology and randomization. In early days, main profiling technologies were expression array, array CGH, cytoscan, IHC, Sanger PCR, and NGS with handful of genes such as 20 to 50. Current major profiling technology is NGS with more than 500 genes with supplementary IHC or FISH. Shiba was the first randomized trial, and Focus 4 is a histology-dependent platform design. I'm going to review briefly about Shiba, NCI Match, Winter, and Focus 4 trials. In precision medicine, there are two designs of trials: exploratory and expansion platforms. Exploratory platform is a signature finding trial. Initially, patients are randomly allocated to several treatments, and then do tests to find out new biomarker drug match signal in an adaptive fashion. Battle trial, I-SPY 2 trials belong to this category. Expansion trial is a confirmation study for previously found biomarker drug match signal. Expansion 1 tests each match in a multi-arm platform, and expansion 2 tests pooled matches to a single control group. A means histology dependent and B means histology agnostic trial. Focus 4 is an expansion 1A type, NCI match is a 1B type, Pangea is a 2A, and Shiba is a 2B type. Shiba trial is the first randomized phase 2 trial comparing molecular profiling-based treatment versus conventional treatment. Primary endpoint was PFS, and feasibility endpoint were proportions of biopsy after getting informed consent, tumor cellularity of greater than 50%, DNA extraction, sequencing, profiling, eligibility to treatment, and turnaround time between biopsy and profiling. The basic assumption of this basket trial is that treatment effect is homogeneous across the signal pathways in a cancer-agnostic pattern. NGS was the main profiling with supplementary cytoscan and IHC in Shiba trial. The drugs were approved one in French with allocation of outside their indication. In each arm, same tumor types and histology were kept to 20% to prevent histology-induced bias. 2 in 200 patients, 741 patients were screened. Among them, 67% got molecular profiling, 40% were matched to drugs, 26% were assigned to treatment, and 13% got experimental drugs. Unfortunately, there was no differences in PFS between molecularly targeted treatment and physician's choice. So the conclusion was molecularly targeted agent off-label use did not improve PFS compared to physician's choice. Therefore, off-label use of molecularly targeted agent should be discouraged, and enrollment in the clinical trial is encouraged. There were several issues from Shiba trial that are responsible for the failure. There was a high screen failure that only 13% of screened patients got the targeted treatment. The treatment algorithm was unidimensional without any consideration for combination, and sometimes the drug was matched incorrectly. In patients with multiple aberrations, monotherapy induced treatment resistance, and some drugs had weak potency as they were approved only in France. Patients were heavily pretreated who were hard to get benefit with monotherapy. Single biopsy could not represent the spatial and temporal tumor heterogeneity. As a result, only 5% of enrolled patients got treatment effect. NCI match trial is a signal-seeking basket trial where the known effective target treatment in some histology might exhibit similar effectiveness in other histology. This study design is like this. After getting sequencing, if the patient have actionable and druggable target, the patient get targeted treatment. Regardless of initial response, after PD, the patient has a chance of second allocation to treatment. If PD occurs within 6 months of treatment, the patient can be allocated based on the initial profiling information. If PD occurs after 6 months of treatment, the patient needs second biopsy for the second allocation. The profiling was done using NGS with supplementary IHS and PC for P10 and MSI study. The protocol was proceeded based on the Simon's 2 stage. In the first stage, if 5 patients among 13 patients showed ORR, it was acceptable for the second stage. The primary objective was either ORR of 25% or higher, or 35% or higher fraction of SD lasting longer than 6 months among 31 evaluable patients. After interim analysis, the match protocol was amended. Initially, NCI match trial planned to screen 3,000 patients, starting with 10 sub-protocols. Flash biopsy was mandatory, using NGS with 143 genes. With the 36 days of turnaround time, the treatment enroll rate was 49%, and the matched rate was only 9%. Based on this frustrating result, NCI revised the protocol to increase the patient number to 6,000, accept archival tissue of less than 6 months old, use NGS system with 200 genes, increase the sub-protocol number to 24 and the later to 40, and reduce the turnaround time to 14 days. With this modification, NGS success rate increased to 94% and match rate increased to 25%. By 2019, 12 of 35 sub-protocols have reported out, and as you see in green box, among 12 protocols, 25% showed success statistically, which will move on to expansion or phase 3 trials. When we compare the SHIVA and NCI match trials, NCI match included more genes in profiling, more subprotocols, and required less amount of sample, which accelerate a higher match rate. As you see in green box, NCI match also included combination strategy under the concept of a level of evidence, which upgraded the drug and biomarker selection criteria. To prevent screen failure, NCI adopted archival tissues. To increase patients' accessibility to trial, NCI is managing the trial in a nationwide scale that finally accelerates the match rate. There are many points what we have learned from NCI match. As feasibility is established, site must have many available treatments, and investigators must be familiar with drugs in all types of cancers. Volume of patients seeking profiling is much larger than patients where molecular profiling is not required. Too early to judge the benefit, but there is a hint that suggests a cancer agnostic activity. Collaborative nature of the study is the most important one to be learned. It is important to increase the breadth and quality of genomic assay to prevent screen failure and also decrease turnaround time not to lose the PD patient during waiting period. To increase match rate, it is also important to increase the available site to patient. However, there are still challenges to solve. It is inevitable to perform unwieldy large protocol. It is also inevitable to accept enormous resource consumption for the management of trial, tumor mutation board, and the multiple protocol amendment. But once on balance, basket design is probably better than multiple individual trials. There must be more focusing on rare molecular alterations because the prevalence of druggable alteration is commonly less than 3%. Winter trial is the first trial that uses both genomics and the transcriptomics platform to navigate the patient to cognate treatment. Primary goals are evaluating the predictive performance with both DNA and RNA, and the clinical benefit with the PFS ratio and ORR. Molecular profiling was done by NGS for DNA and by expression array for RNA. Among 303 enrolled patients, 83% had biopsy, 52% had enough sample for both DNA and RNA assays, and 35% received targeted treatment. As you see in green box, the fraction of PFS ratio higher than 1.5 was 20% and 26% in DNA-based allocation and RNA-based allocation respectively, showing no difference. RNA-guided treatment was selected only when there was no actionable DNA alterations or when DNA-matched drug was unavailable, not a DNA and RNA combined assay. This trial showed the possibility of novel paradigm shift to RNA-based precision medicine. Focus 4 trial is a multi-arm, multi-stage seamless phase 2-3 trial of umbrella design under master protocol. Each molecular trial will be analyzed entirely independently of other trials as a randomized phase 2 design. In a master protocol, patients without targetable aberrations or patients who do not have profiling information due to poor sample quality and amount will be categorized as a reference group with placebo or best supportive care. New trials can be added and the failed trials will be dropped out. In the retrospective study, 31 drugs were tested in FDA-approved genome-driven trials between 2006 and 2018. 75% was genome-targeted drug and 25% was genome-informed drugs. As you see in the left side table, there were improvements in numbers of eligible patients and patients with beneficiary from both types of drugs. In the right side graph, blue and gray lines are changes of eligible patient. Red and yellow lines are changes of patient with beneficiary during last 15 years. The calculated yearly general increment was 0.5%, whereas it is increased to 2% with NGS profiling. Since the first basket trial with imatinib in 2001, 83 master protocols were performed in 2019. Most of the basket and umbrella trials were phase 1-2 exploratory types, while platform trials were phase 3 trials with randomization. The major driving forces of accelerated progress in precision oncology were development of a broad portfolio of drugs, upgraded NGS technology, and novel trial design. However, as you see in this map, most of precision oncology is being done in Western Europe and North America. In Asia Pacific region, only Korea and Australia are doing it relatively actively. Speaking in other way, this is a good chance for the future Asian multinational precision medicine through AOS infrastructure. I really do hope that Asian oncology strategy or organization for precision medicine will be developed in the very near future. Now, I am going to tell the way to go. As the NGS technology improves with the rapid development of drugs, the precision medicine concept evolves very rapidly, which is hard to catch up in real time. As the molecular biology technique improves, the profiling gene number increased more than 500, and the less amount of tissue, such as 10% tumor cellularity, was acceptable for profiling, which reduced the number of screen failure. Contrast to SMV in previous profiling, future NGS will give information about CNV, fusion, MSI, TMB, EBV, and HLA typing, which will boost the signal search for the targets with unknown clinical significance and increase the drug-to-target match ratio. For the optimal design tree, for the optimal decision tree, information about tumor heterogeneity from rebiopsy, upgraded information about the level of evidences, and drug combination data will be added continuously. With this system, we can choose the best single drug from multiple aberrations, even with information about the wild-type genes. On the contrary, you can also choose triplets from single gene aberration. The drug itself is not a big issue, but speed of drug development is matters. We have more than 100 drugs right now, and during 2018 to 2019, FDA approved over 100 new treatment indications. It is totally impossible to match operations from 500 genes to 100 drugs with multiple combinations by clinician's hand. To support clinicians in selecting right drug to right patient on right time, machine learning predictive model will be an issue. Currently, there are many examples of machine learning developed from academia, pharmacia, government, and organizations. For the best operation, continuous update of a specific gene with specific mutations in a specific cancer type, either histology specific or histology agnostic level of evidence after treatment is required by clinicians from all around the world, especially from Asia Pacific region for Asian patients. Currently, there are many limitations in precision oncology out there. For stage 4 disease, genomic information from metastatic site is more practical than from archives of primary tumor, considering spatial and longitudinal heterogeneity. This issue can be solved by clinicians' interest. For developing optimal algorithm of patient allocation to a specific target, support from bioinformatics and biostatistics is mandatory. Some genes are mutational in normal tissues like HLA, HRR, and MSI, which are futile to target. These can be used as a marker for immune treatment or toxicity monitoring. Multimodality support from geneticists, immunologists, molecular biologists, pharmacologists is a prerequisite to solve this limitation. The goal of precision oncology is moving survival graph from here by chemotherapy to here by precision oncology. For this purpose, we use NGS as a matchmaker between biomarkers and drugs on top of chemotherapy backbone. This is the reason why clinicians' understanding of NGS profiling is the most important factor in performing precision medicine. Long time ago, in an ancient precision oncology area, which is only 10 years ago, less than 10% of screened patients were enrolled to targeted drug. But now, almost all patients are allocated to right target, right drugs, even in patients having long tail aberrations. How can we make the best strategy of precision oncology in Asia? I'm sure it can be done only through multimodality teamwork from multinations via AOS umbrella or AOS platform. Thank you for your attention. Please pray for cancer patients who are infected with COVID-19 or facing quarantine. And thanks to all frontier lines for your sacrifices for cancer patients in the battle against COVID-19. Stay safe.
Hello.
Hi.
Yes. Okay. Good afternoon or good evening to everyone who is joining this live session. I am Dr. Heinrik Strebel, and I'm joined by Professor Hyun Chung, who has presented a wonderful review on NGS and its role in precision oncology. Okay. I think one of the questions that came up from the audience involves the use of arrays. Someone is asking about the difference between array comparative genomic hybridization and as opposed to sequencing, next generation sequencing.
Okay. Hybridization is we call oligomultiplex. we can use usually 10 to 20 genes. And in NGS, initially we started with 50 genes. Right now we are using more than 500 genes. So scale is different. And the other one is in NGS, we have more multiple content. We can detect a single mutation and copy number change, and sometimes fusions. And right now we have some immune markers. So the number scale and the content is different compared to RHCGH and NGS.
Okay. So yeah, I think essentially what you want is you want to detect more genomic alterations, and you're better suited to do that with sequencing rather than with the array. But I'm curious. During the presentation, there were centers that used backup cytoscan also. Do you think that, there are still some alterations that will be captured by the cytoscan even if they already have NGS?
That was very old times.
Yeah.
When
Okay.
we post generation.
Okay.
At that time, the number is small. The institute used both NGS and some CGH or sometimes IHS. So right now, we usually mostly NGS first, if the number is enough. And then sometimes we add some MSIH or some specific biomarkers like P10 deletion. In that case, we use some IHC. Otherwise, NGS single use is enough.
Yeah, okay. Because yeah, I was thinking for a moment that most centers who are planning to invest in genomic profiling would probably be faced with a decision to choose an array or a sequencing. But right now, the weight of the evidence favors sequencing overall. Okay. For patients who do get a genomic alteration in which there is no available therapy, in your country, do you just go to the next best, or are you able to get the drugs within 2 weeks? What happens to those patients who okay, we find the alteration, but we can't offer the best therapy for them? Do you just go down the line to what's next best?
So that's very tough situation.
Yeah.
So for the initial stage of NGS, technology was an issue. But right now, the technology is okay. So next stage is drug. If there is not enough drug, there's no need to do NGS.
Yeah.
So the
Yeah.
major
So
bottleneck is drug. So if you have enough drug, then you do NGS. But if not, there's no need to NGS.
okay.
And the third bottleneck will be the patient pool. The frequency rate is usually 3%. So we need a large population of patients or population of screening patients. So in that case, we need some multinational or multi-institutional network to screen the patient.
Okay. Okay. So yeah. I think before we do comprehensive profiling, we should have a comprehensive set of drugs also. Okay. So for those places who will be starting NGS and they might be thinking of doing hotspot instead of comprehensive profiling, would you recommend like testing the 100 genes, let's say?
So if you have a small number of drugs and the target is enough, 100 genes enough for your drugs you have, then it's enough. So it depends on the drug, not the gene of interest, not the
Yeah.
patient. Initially, you must focus on your drug, and then you expand to the scale based on your patient number.
Very much. I think that's all the time that we have. So we have to turn over back to the. Thank you for everybody who joined us this afternoon and this evening. Thank you very much to all of you.
Thank you. Bye.
Bye.